Good morning, I'm Dr. Nicholas Tedesco D.O, Co-Associate Program Director for Good Samaritan Regional Medical Center's Orthopedic Surgery Residency Program. Today I'll be lecturing on total hip arthroplasty complications as part of our ongoing online lecture series that's going to supplement the in-classroom case-based learning. In terms of disclosure, I do own stock in ROM Tech, which is a small orthopedic rehabilitation company. It has nothing to do with this talk or any of my others this year. So in general, the most common cause for revision of total hip arthroplasty within 8 years of the index procedure is instability or dislocation by far number 1 and mechanical loosening number 2. Infection is third at 14.8%. So we'll start off with intraoperative fractures and specifically the acetabulum. So this is very rare. With cemented, it's lower than press fit, obviously because of the increased impaction force of press fit components. There are multiple risk factors to this, including under-reaming by greater than 2 millimeters, where you have to impact the cup extra hard to get it to seat, elliptical modular cups as opposed to hemispherical, osteoporosis, a press fit implant as we just talked about, presence of hip dysplasia, and previous radiation to the pelvis. The classification of fractures is based on the Judean-Letournel acetabular classification system, and it was modified specific to arthroplasty by Peterson et al., where it could just involve a medial wall fracture, which is generally what's seen in total hip arthroplasty patients where the rim is still intact, and type 1 would be involving a stable component that can be left in place and treated non-operatively versus an unstable component that will need to have the cup extracted and revised. Treatment is usually observation as long as it's minimally or non-displaced and you have a well-fixed component with screw placement into the ilium. So intraoperatively, if everything's found to be stable, you can treat it with protected weight bearing for 8 to 12 weeks with serial radiographs. If there is displacement or instability of the components, then you may need to revise the cup. You may need to add an open reduction and internal fixation with screws or plate osteosynthesis. You may need a cage, you may need a cup cage, so it all depends on the location and the type of fracture. Pelvic discontinuity is essentially equivalent to a transverse acetabular fracture where there is a complete dissociation of the upper from the lower pelvis and the posterior from the anterior. So this may need a cup cage construct. You can consider posterior column plating to augment the fixation, or you can consider oversized cup distraction fixation, where essentially you ream and then you take a cup that's 4 to 6 millimeters larger than your last reaming and impact it. And what that does is it diastases the fracture, but the ligamentotaxis on both sides of the pelvis is so robust from all of the muscular and ligament attachments that essentially it will clamp down on that distraction and still provide stable cup fixation with that approach. So here's just a pictorial representation of the Judean-Letournel classification. Again, it involves the simple types and associated types that you learn in trauma, and it's no different for intraoperative pelvic fractures during total hip arthroplasty. Intraoperative femoral fractures are much more common, up to 5%, typically with press fit. Cemented is obviously much more rare and usually occurs during dislocation and relocation of a trial with a spiral oblique fracture, especially in an osteoporotic individual. Revision of the femoral component will likely be needed in up to 30% of these patients when there is an intraoperative crack. The mechanism is usually dependent on the region of fracture. So proximally, there may be overaggressive rasping or broaching and or an implantation mismatch in terms of size or dimensions with the medial lateral press fit taper or the A to P dimensions. The middle portion of the stem fixation region of the femur fails often with excessive force during exposure or bone preparation with the broaches, and usually what will happen here is a calcar split. And then distal fractures occur, usually with straight stem impacting along the anterior bow of the femur, or again, as we mentioned previously, a spiral oblique fracture during dislocation and relocation of the trialing of implants. Risk factors for this are very similar in terms of osteoporosis, female sex, and press fit components, as we saw with the acetabulum. However, the addition of impaction bone grafting, technical surgical errors, if this is done in a revision setting or with the direct anterior approach, those can all increase the risk of femur fracture as well. The classification is the Vancouver, which has been modified by the same folks in Vancouver to the Unified Classification System to be applied to all prosthetics. The intraoperative additions are a subtype of 1, which would be a simple cortical perforation, such as putting your stem out the back of the femur or out the anterior bow on a long stem. and subtype 2 is a non-displaced linear fracture, and subtype 3 is a displaced or unstable fracture that will require intraoperative fixation. So the Vancouver classification involves A, subtype G for greater, and subtype L for lesser trochanter fractures. Greater trochanteric fractures may require a trochanteric hook plate or treatment non-operatively with no active abduction, as long as there's an intact muscular sleeve still attached to the upper end of the femur that will prevent migration of the greater trochanteric fragment. Lesser trochanteric fractures depend on where they occur. If they occur and involve the calcar, typically they will need wires and a reimplantation of your implant. However, if it's just a fleck avulsion, it can be treated non-operatively. Subtype B are fractures around the actual stem of the implant. A B1 is a fracture around the stem with a stable implant that's not loose and can just be fixed with a plate and wires or plate and screws. Subtype B2 is a fracture with an unstable stem that typically has subsidence or an angular change or even rotational change in the component. This usually will require revision of the component as well as internal fixation, although some studies are now showing that internal fixation alone may be satisfactory and you can get secondary bone ingrowth and ongrowth back to the prosthesis with a good reduction. Vancouver B3 is a comminuted fracture with unsupportive bone and an unstable implant once again. This is going to involve typically internal fixation with or without strut grafting, as well as a long stem revision arthroplasty to bypass this region. Subtype C is going to be distal to the implant, typically can be treated with just plate and wires or plate and screws. The unified classification or universal classification now can be applied to all artificial joints, which you can see there on the left, so apophyseal or extra-articular fractures, just like in the Vancouver classification of the greater and lesser trochanter. B is in the bed of the implant or around the implant. C is clear or distal to the implant. D is dividing the bone between two implants, so for instance a midshaft femur fracture with the presence of an artificial hip and knee. Subtype E is each of two bones supporting one of the arthroplasty or polyperiprosthetic. So this would be a combined distal femur proximal tibia fracture around a knee replacement. F is facing and articulating with a hemiarthroplasty. So you have a well-fixed hemiarthroplasty, but you have a fracture in the contralateral side of the joint. So for the hips specifically, it's as we just talked about with the Vancouver classification with the addition of D, E, and F, and I'll let you pause and read that on the right there. So intraoperative fractures of the femur, treatment, subtypes A, typically you'll ignore a subtype 1, maybe a plate or wires if needed, if you're worried about secondary displacement. Subtype 2 will typically need cerclage wires, cable, a hook plate, depending on what's needed. If it involves the calcar, you may need a long distal stem plus cerclages. You may be able to get away still with a short stem with cerclages, but you will need to support the bone and rebroach and reimplant your femoral component. With a Vancouver B, subtype 1, you'll need a longer stem and you'll need to bypass this region by 2 cortical diameters if you're going to revise it. However, as long as it's well fixed, you can get away with just internal fixation. Subtype 2, you'll need a longer stem, cerclage wires, strut graft, or plate and screws if it can't be bypassed with the longest stem. And subtype 3, as we talked about previously, usually you will need some sort of additional bone grafting or strut grafting proximally if it's comminuted enough that plate fixation alone cannot satisfactorily reduce the bony fragments around the femur. Subtype C and D can get away usually with just an open reduction and internal fixation with or without a longer stem to bypass it if there's an unstable implant. Subtype E is very uncommon, may need open reduction and internal fixation plus or minus bone graft. And subtype F, you may need to convert to a total hip arthroplasty with addressing the acetabular fracture as previously mentioned. So postoperative periprosthetic fractures is another mode of failure, so not necessarily intraoperative as we have just discussed, but where the patient fractures postoperatively either early on or late from a mechanical fall. So these are rare with up to 3% incidence, typically more common in press-fit arthroplasty compared to cemented. You do need to evaluate for possible infection if there's an unexplained mechanism that may hint at a pathologic nature of the fracture. The acetabulum is very rare to fracture postoperatively and usually from direct impaction of the head. If the cup is unstable, you will need to revise the cup with or without internal fixation as we discussed above. On the femur, in terms of Vancouver classification, very similar. in terms of how you're going to manage this, and it's going to be largely non-operative for a greater troch fracture. Unless it's displaced or at risk for displacement, then you'll need to fix it. Lesser trochanter avulsions can be treated non-operatively, but if it fractures and involves the calcar, that can destabilize the implant and will need fixation with or without revision. Subtype B1, you can get away with open reduction and internal fixation alone. B2 usually will need a revision to a longer stem with internal fixation, as we talked about previously. And subtype B3, usually a long stem revision with structural allograft proximally. Subtype C, open reduction and internal fixation, and treat it as though it's separate from the implant unless the implant is also loose. Dislocation, as we talked about before, is one of the most common reasons for revision within 8 years of surgery. Incidence is 1 to 3%, and 70% of these occur within the first month post-operative. Up to 90% of dislocations are posterior, with the remainder being anterior. The mechanism for posterior is flexion, internal rotation, and adduction. The mechanism for anterior is extension, external rotation, and adduction. On presentation, the patient will usually report being in one of those positions, such as bending over to tie shoes, sitting on the toilet seat and trying to get up, or rolling over in bed into the fetal position. That puts them into that flexion and internal rotation position. Workup requires x-rays, obviously, and you do need to be very diligent to look for signs of periprosthetic fracture and osteolysis as well. You will need to look for eccentric polyethylene wear, especially after reduction, to see if this may be the risk for a late dislocation. You need to consider infection or trunnionitis workup if this happens late without obvious evidence of eccentric polyethylene wear. There are multiple risk factors for dislocation that are related to demographics, neuromuscular disorders, cognitive dysfunction, implant-related problems, and surgery-related issues that most often can be surgeon-mediated. I'll let you pause the video and read this because all of these are testable topics. Not only that, but all of these must be taken into consideration in preoperative planning for patients to try and help prevent dislocation. So for demographics, neuromuscular and cognitive issues, there seems to be a predisposition in women, perhaps due to increased hip range of motion in general in women compared to men, with more compliant soft tissues that may help destabilize the joint and decrease soft tissue tension. Age seems to be a risk factor, but there are many confounding factors with this, including neuromuscular and cognitive deficits, more comorbidities as we age, and the presence of fractures due to osteopenia and osteoporosis. Preoperative American Society of Anesthesiology score of 3 or 4 does contribute to risk of instability. Neuromuscular diseases, so contractures, poor muscle control, altered muscular balance, and unfavorable body mechanics will decrease tension and control on the hip, which can increase instability. And then cognitive dysfunction. There may be an increased risk due to an inability to comply with activity restrictions or a lack of coordination or balance that may contribute to all of these issues. So preoperative diagnosis does matter in terms of hip dislocation, whether it's conventional age-related osteoarthrosis versus another reason. So if there's a hip replacement being done in the presence of trauma, particularly for a femoral neck fracture, there's often concomitant soft tissue injury that's not well appreciated that will decrease soft tissue tension and increase the risk of dislocation. Developmental dysplasia of the hip, no matter how severe, can increase the risk. Avascular necrosis increases the risk, typically because this process occurs so rapidly compared to the decades-long degenerative process that in age-related osteoarthrosis, the joint shortens and all of the tissues contract around it and they all tighten up with time. With avascular necrosis, it happens so fast those tissues can't tighten up and they're too loose, and so typically with avascular necrosis, another big risk here is leg length discrepancy because you have to lengthen them in order to get that soft tissue tension, very similar to developmental dysplasia of the hip as well. So you do need to counsel these patients ahead of time that they're the most likely to end up with a leg length discrepancy, what that means, and how you're going to treat it if it happens. Rheumatoid arthritis also represents a risk factor for dislocation, again likely due to the soft tissue problems associated with that disease as well. Prior hip surgery is a significant increased risk for dislocation. It doubles the risk. And they may have bone loss or deformity, they may have abductor dysfunction, they may have insufficient external rotator muscles, and they may just have excessive scar tissue that does not function like normal ligament and muscle. Implant issues are related to head and neck offset. So a smaller head neck offset leads to impingement, which can cause a fulcrum effect to dislocate. So if you don't increase your offset appropriately, your greater trochanter can impinge on the pelvis in abduction or the cup in external rotation or flexion and lever the hip out. Increasing the head neck offset increases the impingement-free range of motion. Head size matters because of what's called jump distance. So the larger the head, the larger the jump distance to lever it out of the cup. So it makes it less likely to dislocate. Smaller heads are more likely to dislocate. However, larger heads are associated with increased polyethylene wear because of the increased surface area or contact with the polyethylene. So you do need to weigh the risks and benefits of each of those things dependent on all of those other patient factors we've just discussed. The liner profile matters. Theoretically, elevated liners improve stability by providing support, but there's been no real difference at midterm follow-up compared to standard liners. They can cause decreased impingement-free range of motion because of the elevation of the liner hitting the neck at earlier range of motion, and so they may actually increase the dislocation risk, particularly if the elevation is placed in the wrong conformation. Wear or deformation of the polyethylene can cause dislocation simply by decreasing the contact area of the head in the pelvis. That can cause it to rattle around, destabilize, and secondarily dislocate. Surgery-related issues are related to surgeon experience, so it has been shown that the first 100 cases that surgeons do when they get out into practice do have a higher rate of dislocation than later in their practice. The approach does seem to matter, so an intact posterior capsule and external rotators are of the utmost importance, given that 75 to 90% of dislocations are posterior. It has been shown that closing the posterior capsule on a posterior approach does slightly decrease the risk of dislocation. When you look at the incidence based on approach, there's a 3% risk of dislocating if a posterior approach is done, 0.6% direct lateral, 0.6% anterior, 2.2% anterolateral, 1.3% transtrochanteric, and 0.5% with the superior capsulotomy. With the posterior approach, repair the capsule and external rotators, as we just discussed, can lower that dislocation rate. Implant positioning matters. What's generally considered the safe zone is 40 degrees of inclination and 15 degrees of anteversion of the acetabulum. However, this may change depending on the degree of spinal pathology, as there is a close interrelationship between spinopelvic mechanics and hip stability. An excessively retroverted or under-anteverted cup increases the posterior dislocation risk, so it may not be retroverted itself, but it may be only 7 degrees of anteversion. So if you're under-anteverted, that can be just as bad as frankly retroverting a cup. However, if you excessively antevert a cup, that can increase the risk of anterior dislocations, usually with external rotation and the neck contacting the cup, causing it to lever out and dislocate anteriorly. With the femur, you want it in 10 to 15 degrees of anteversion. It's rarely the isolated cause of dislocation, but there is something called combined version, where you look at the anteversion of the femur, anteversion of the acetabulum, and combine the two, and typically you're looking for about 30 to 40 degrees of anteversion combined. So if you have a retroverted femur, you want to perhaps excessively antevert your cup and vice versa. Femoral offset matters, as we talked about before, decreasing trochanteric and neck impingement. Varus and valgus malpositioning affects rates of mechanical loosening, and once an implant is unstable, then the hip joint itself can become unstable. Extra-articular impingement can happen with bone-on-bone or bone-on-implant impingement. You can also have soft tissue interposition between the implants as they move that can lever one out or the other. Primary type occurs at the time of surgery, and secondary occurs after the formation of heterotopic ossification. Treatment of dislocation non-operatively would be a closed reduction with or without immobilization. You can do that with a knee immobilizer or an abduction brace. For surgical treatment, it will involve an open reduction, usually will require a revision of some sort, even if it's just acetabular liner and femoral head. This is usually indicated once there are 2 or more dislocations or evidence of a mechanical reason as to why it has dislocated. Likewise, if you see poorly aligned components that have placed the patients at risk, you should revise those at the time of surgery. You can increase the size of the head and consider a trochanteric osteotomy and advancement to improve the soft tissue tension of the abductors if they are loose or they have poor tension. If all else fails, you convert to a constrained acetabular liner. The advantage of this is it's good for inexplicable dislocations or for poor soft tissue tension. The big disadvantage is it limits range of motion and it does impinge early, and it may lead to fracture of the constrained ring or frank cup loosening from the pelvis from all of the levering force on the entire construct rather than just a free head that might dislocate. You can convert to a hemiarthroplasty with large head, typically a dual mobility type construct when you're talking about total hip arthroplasty as opposed to a hemi-hip arthroplasty. And if all else fails, a girdle stone resection arthroplasty can be done. This is usually done as a salvage operation when there's significant bone or soft tissue deficiency and or psychiatric patients intentionally dislocating for secondary gain. Infection is one of the more devastating complications of total hip arthroplasty. As a result, we have an entire lecture dedicated to infection, so I'll avoid delving into this topic too deeply, but just some general information. Prevalence is 1.6% within 2 years of the primary surgery, about 0.6% between years 2 and 10, and it accounts for up to 15% of all revisions. White blood cell count, ESR, and CRP is always done as a screening whenever you're concerned, and then aspirate the hip if those are concerning as well. You can discuss debridement, antibiotics, and implant retention, known as the DARE procedure, versus a one-stage versus a two-stage revision versus resection arthroplasty to manage this depending on where you're at in the treatment algorithm. And again, we go over that in much more depth in the PJI lecture. Implant failure is another reason for a complication in total hip arthroplasty that may require revision. Clinical implant failure is seen in most patients with aseptic loosening and or malposition, incorrect sizing, or improper fixation techniques. A material implant failure is a true implant failure. This is what leads to recalls and class action litigation. Improper material selection can do this, design flaws, manufacturing problems, or in vivo changes in material properties, usually due to corrosion. So clinical failures, predictors of total hip arthroplasty aseptic loosening are males when the primary surgery is done at a young age, and when they have a high Charlson comorbidity index. The cause is often difficult to pinpoint, usually multifactorial, a combination of biologic, biomechanical, and genetic factors. Technical errors can play a role, so a classic example is a cemented varus stem. Increased cement mantle leads to fragmentation of the cement. Macrophages then come in to try and clean that up, which release cytokines, which lead to loosening and osteolysis. Genetic factors play a role. There's a promoter of the MM1 gene, increases the risk of loosening, and polymorphisms in mannose binding lectin is associated with early loosening in some patients. Here's just an example of what the Charlson Comorbidity Index scoring system is, and at the bottom there you can actually see the role that this plays in mortality rate following surgery. And what's rather alarming here is you see even in very healthy patients with a low CCI score, the annual mortality rate is 3%. So 3% of healthy patients will not be alive 1 year after a total joint arthroplasty. Up to 50% of patients with a high CCI score will not be alive within a year of the index surgery. So it is very, very important to modify, adjust, and improve risk factors preoperatively when considering such an elective surgery that's potentially deadly. Aseptic loosening and osteolysis of the acetabulum. We talk about the De and Charnley zones around the acetabulum. So it's based on the order of progression, and the component is usually considered loose if radiolucency is seen greater than 2 millimeters in all of the zones, a progressive radiolucency in zone 1 and 2, or a change in component position. Upon implantation, zone 2 lucency means nothing for a rim fit component because it will fill in with bone, which depends on zones 1 and 3 for stability. A hemispherical component, however, does depend on all zones, and thus a zone 2 lucency may mean the component is unstable. So the way you do this is you look at the AP radiograph of an implant, you pick the center of the femoral head and draw a vertical and horizontal 90-degree line, and that's what divides zone 1, 2, and 3. For loosening and osteolysis around the femoral component, this now involves what's called the Groin Zones, and again based on the order of progression. Radiolucent lines in zones 1 and 2 with distal cement fracture or radiolucent lines in all 7 zones is indicative of pistoning subsidence. Medial migration of the proximal stem and lateral migration of the distal stem into varus with cement fracture in zones 2 and 6 is indicative of medial stem pivoting. and radiolucent lines in zones 3 to 5, with or without a sclerotic bone at the stem tip, are indicative of calcar pivoting with windshield wiper effect. Fracture of the component stem with radiolucent lines in zone 1, 2, 6, and 7 are indicative of loss of proximal cement support with resultant cantilever bending of components. It's critical that you guys understand this slide and those modes of failure because that is also testable. A lot of them are intuitive when you really think about if a stem were to medially pivot or piston or windshield wiper, what would that really look like in the femur? But it's important to understand this concept. The way you come up with where the Groin zones are drawn on your AP radiograph, essentially it's from the shoulder of the stem laterally and proximally right below the greater trochanter. That's the beginning of zone 1, and that extends down to the tip of the lesser trochanter. Across from that is zone 7. Zone 2 then is from that delineation to a point where the end of the taper of the metaphyseal component ends, and zones 3 and 5 are then down into the femoral isthmus. Zone 4 is distal to the stem. So a true material failure is a failure of the actual metal, plastic, or ceramic in the hip. These are very rare, and they usually result from design failure or late biologic response with corrosion, fretting, and then a failure of the component. These failures were common in the early days of arthroplasty, which has led to all of our improvements in technology and design. There are 3 broad types. There's the bearing articulation, the surface coating on the backside of the acetabular cup and on the femoral stem, and then there's substrate. Substrate failures are rare and catastrophic failures that require immediate surgical intervention. So substrate is the actual material itself. So right here is a picture of a broken stem. That would be a substrate failure. So a material failure, typically involving a bearing failure, is metal on polyethylene as the gold standard in primary total hip replacement. It's been around since the beginnings. However, it is known to produce osteolysis. Highly cross-linked polyethylene is the current standard in the United States, about 80% of primary total hips. It has improved wear characteristics, but does weaken the plastic and decreases fracture toughness. Sterilization in air increases oxidation, which increases wear rates, subsurface cracking, and delamination, which leads to failure of the plastic and then extensive osteolysis as a result of a macrophage-mediated response to the debris. Therefore, this needs to be sterilized in inert gas. New techniques with remelting and vitamin E polyethylene are now becoming much more of the standard to decrease oxidative stress of the plastic. Metal-on-metal components were initially introduced in the 1960s but discontinued because of early failures. They were reintroduced in the 90s and early 2000s. The thought of this was the very low wear rates and the fact that the metal will last longer than the plastic. The problem is it increased the metal ion levels in the blood, urine, and locally, which led to pseudotumor formation, which is an aseptic lymphocytic vasculitis-associated lesion, or ALVAL lesion. What this is a locally destructive immune-mediated response that can actually eat all of the patient's soft tissues and bone in its pathway, which can lead to dislocation, frank mechanical failures, and present significant difficulty with revising these components. Ceramic on ceramic have very low rates. They are relatively inert and don't lead to the problems that metal on metal does, but the problem is they have a higher rate of liner and head fractures. They are very high cost, and squeaking is a big problem. Stripe wear happens from point loading if things aren't aligned exactly perfectly, so there's enough problems with ceramic on ceramic as well as the high cost that these aren't readily commercially available in the United States currently. Ceramic on polyethylene is sort of the compromise to all of these other issues, but again, fracture of the ceramic can occur. Here's an example of that stripe wear, so you can see where the cup was placed. You can see the large stripe on the surface of the femoral head where it was point loading and articulating with the edge of the cup, probably due to malalignment of the implant. Ceramic on ceramic squeaking, I encourage you to pause your video and type this URL into your web browser because it is extraordinary and almost unlivable. It usually will require a revision surgery if a patient is unfortunate enough to get this complication. This can occur in metal on polyethylene and ceramic on polyethylene, but very, very rarely compared to ceramic on ceramic. Material failure of the surface coating is usually referred to as bead shedding. It was common in early press-fit systems that were used that involved all of these beads on the surface that created pores to allow for bony ingrowth and ongrowth. The problem is the beads were just sort of stuck on the metal stem, and so over time they would shed, especially in the presence of osteolysis. And so here's an x-ray example on the left of the original implant, and then on the right you can see those small metallic fragments in the canal with osteolysis and loosening surrounding the stem, indicative of bead shedding. And there you can see the extraction of the component with the arrow pointing to the area where those beads are off the stem, and just the smooth polished stem is visible below. Metal ion failures and those alveolar lesions, as we just talked about, typically occur in metal-on-metal articulations. There's an increased risk with vertical cut placement greater than 55 degrees. But trunnionisis is another common cause of this as a material failure, usually with a cobalt chromium head on a titanium stem due to galvanic corrosion, due to breakdown at the head and neck junction, if the head is impacted improperly, if any material interposes between the head and neck and disrupts the Morse taper, if there's excessive micromotion. All of these can lead to trunnionisis and increased cobalt and chromium ion levels as a result. With ceramic, usually there's a titanium sleeve or just the ceramic ball itself, so even though trunnionisis still can certainly occur, it's usually the titanium byproducts as opposed to the destructive cobalt and chromium, which is one of the reasons that ceramic has been gaining traction as the primary treatment of choice for femoral heads in total hip arthroplasty in the United States. Pseudotumors are these alveolar lesions that we just talked about. There's cobalt-induced neuro, cardio, and thyrotoxicity that can happen. Unfortunately, it usually is irreversible if it does. Thankfully, this is tremendously rare, but that's what we worry about when we start seeing these problems. The question is when do you revise and when do you work this up in terms of if a patient has a metal-on-metal hip or you're concerned about trunnionisis. And so typically you'll screen them with a serum cobalt and chromium, and we have this rule of sevens that's sort of a loosely defined rule that if either of the numbers come back as greater than 7, then typically you want to talk about a revision, whether or not the patient's symptomatic, because those are the ones that are building up high enough ion levels to eventually cause a problem if they haven't already. If their numbers are below 7, typically what I do is just monitor yearly with a blood check as well as x-rays looking for signs of failure and toxicity. If it ever encroaches or gets above 7, then usually we talk about revision surgery. Heterotopic ossification is our next potential complication. It's frequently seen postoperatively and usually is asymptomatic and not a problem, but some patients will get very robust formation that can lead to impingement, as we talked about, which can secondarily dislocate the hip, or you can actually have complete bony ankylosis and fusion of the femur to the pelvis with concomitant significant decrease in range of motion, as you can imagine. That could constrain everything and significantly increase the risk of fracture as well. So there are many risk factors for this. Being male is one, a prolonged surgical time, excessive soft tissue handling during surgery, the direct lateral approach, the presence of hypertrophic osteoarthrosis with robust osteophyte formation, if they have a history of heterotopic ossification, all of those things play a role. So if you want to prophylax against this in those high-risk patients, you can talk about indomethacin for 6 weeks following surgery, or some other NSAIDs have been looked at, including Celebrex and meloxicam. You can do radiation of one single small dose, about 600 to 800 centigrade, within 24 to 48 hours of surgery. So typically how you would do this is pre-admit the patient. They would go down to radiation oncology, get radiated in the morning, and then that afternoon you'd have them on for the total hip arthroplasty. You will need to communicate with your radiation oncologist because if at all possible, you want them to try and shield the acetabulum and the proximal femur because the radiation can diminish bony ingrowth and ongrowth if you're doing press-fit components. Treatment, if this does show up and does cause a problem, involves surgical excision. It's indicated for severe loss of motion or impingement and dislocation. Usually you want to wait for maturation, which is generally around 6 months, where it looks more like normal bone. A bone scan at that point will be cold, and an MRI would show no longer any significant edema in the area. And that's because as long as it's still active and it's happening, then there's a very high risk of recurrence after surgery. The Brooker classification is the classification that we use to define heterotopic ossification. It's somewhat of a poor classification scheme because it only takes into account the AP radiographs. So there could be the appearance of bony ankylosis when in reality it may be two separate islands of bone that are overlapping on the AP view, but on the lateral view they might be centimeters apart. But class 1 is a small island of bone within the soft tissues around the hip. Class 2 is bone spurs originating from the pelvis or proximal end of the femur that start growing out, but they leave at least a centimeter between the opposing bone surfaces. Class 3 is where you have less than a centimeter between the opposing bone surfaces, and class 4 is frank ankylosis with complete growth across the hip joint. Nerve palsy during and after total hip arthroplasty is uncommon, but up to 3%. The most common is the peroneal branch of the sciatic nerve at 80%, usually because of tethering around the neck of the fibula being intolerant to stretch. So it most commonly occurs when you over-lengthen a leg, but it can occur from crushing with cerclage wires or retraction during exposure of the femur and pelvis, depending on where you put your retractors. The femoral, obturator, and superior gluteal nerves have all been reported as well. Causes, usually compression, the most common, especially post-op, or if it's delayed, you've got to look for hematoma. You've got to look for implant positioning in case there's a screw into the greater sciatic notch that's tenting the nerve. It may not shut it down acutely, but it will over time. If there's excessive retraction, if there's tight bandages, if there's direct trauma to the nerve, if heat from PMMA hits the nerve, and then it's unknown or idiopathic in 40% of cases. Risk factors include DDH again, revision surgery, female, limb lengthening, post-traumatic arthrosis, difficult surgery per the surgeon report, prolonged surgery, increased exposure required, lots of different reasons this can happen. So the presentation, usually post-op numbness, paresthesias, and weakness. Post-op, get a CT or ultrasound if a hematoma is what's suspected as the culprit. Otherwise, x-rays to double check all of the components, and maybe even a CT if you really need to see the three-dimensional anatomy of the pelvis, especially if multiple screws were used or a cage or revision surgery components. An EMG can be done at 3 months to evaluate the level of injury and help prognosticate. Treatment early on is place the hip in extension and knee inflection to decrease the tension on the sciatic nerve and see if it comes around. Surgically, you may need to evacuate the hematoma. Otherwise, you have to remove or change the offending hardware if that's the case. But sometimes they may not resolve if it's a crush or severing injury at the time of surgery. Prognosis is only about 30 to 40% will fully recover their strength after a complete palsy, so these are somewhat long-lasting and devastating if they occur. Leg length discrepancy is usually functional or transient, meaning the patient perceives a leg length discrepancy, but there is not one in actuality or not severe enough to be symptomatic. And so usually it's weak abductors provide sensation for a long leg in the absence of a true leg length discrepancy, and it will resolve within about 3 to 6 months postoperatively as the patient rehabs and heals up. Presentation is they'll perceive a leg length discrepancy despite anatomic equality. It does need assessment postoperative for true inequality, so you measure the ASIS to the medial malleolus either with direct measurements or with a scanogram. And then you do have to look for concomitant knee pathology, especially if they have a fixed flexion contracture. That will give the artificial appearance of a shorter leg. Likewise, if they have a varus or valgus deformity of the knee, that can give the perception of a shorter leg. On imaging, you measure it based off of the AP pelvis. An increase in neck length will lead to an increased leg length discrepancy. However, femoral offset should not increase the leg length. What you measure is with a straight line on the inferior portion of the acetabular teardrop or the ischium to the level of the lesser trochanters or the center of the femoral head. For prevention, preoperative planning does reduce the incidence. And for treatment, usually a heel or shoe lift is adequate in most cases versus observation, and wait 6 months for those muscles to relax before addressing it further. Likewise, you may need to address the other pathology such as the knee. Leg length discrepancy is the most common reason for litigation following total hip arthroplasty. Operative limb lengthening is the most common. True versus apparent, so a true leg length discrepancy, as we talked about, is when you measure it and it is actually off. Likewise, you may not have lengthened them during surgery with the hip construct, but they may have a true leg length discrepancy for some other reason where they have a longer tibia than the other side. An apparent leg length discrepancy is where on radiographs it will be measured the exact same, but the patient still does perceive it, and that's the one that we just kind of talked about. So here's how you might measure the leg length discrepancy using different anatomic landmarks. Iliopsoas impingement is another complication following total hip arthroplasty. It tends to be under-recognized as a cause of recurrent and ongoing groin pain after total hip arthroplasty. The causes are usually retained cement that's sticking out or a malpositioned acetabular component with excessive anterior overhang like seen down in that CT scan below. A leg length discrepancy can do this because it tightens the iliopsoas around that anterior pelvic brim, and excessively long screws, particularly anteriorly or superiorly, can hit it as it traverses through and out the pelvis. Evaluation could be a diagnostic cortisone injection into the tendon sheath, otherwise imaging looking for that excessive anterior acetabular overhang. Treatment is usually revision of the component if it's correctable, otherwise an iliopsoas tenotomy or resection, and just let it fly. Otherwise you can do the injections as therapy or physical therapy to see if it resolves over time. Finally, ogilvy syndrome is a very rare and malignant form of postoperative bowel pseudoobstruction characterized by massive dilation of the large bowel, which, if untreated, leads ultimately to colonic perforation, peritonitis, and possibly death. It's rare following joint arthroplasty, but if it occurs, it does have a high morbidity and mortality, and total joint arthroplasty is the most common overall cause of ogilvy syndrome. Prompt recognition is needed with expedient general surgical intervention to avoid potentially fatal consequences. So part of this is rounding on the patients postoperatively and double checking that they are passing flatus or having bowel movements. If they're not, if they're distended, if they are developing signs and symptoms of an obstruction or ileus, this should be addressed promptly with decompression, nasogastric tube, and NPO. So you do want to get your consultants involved to get this addressed right away because it can be fatal. Thanks for listening to this talk. So I'll leave you with my Pacific Northwest Pride slide. There's a shot of the skyline of Seattle from Puget Sound. Great city to visit, and I encourage you if you get the opportunity.